Today, I'd like to talk about tafasitamab, or MONJUVI plus R squared, which is an NCCN Category 1 preferred treatment option for second-line follicular lymphoma. Hello, my name is Dr. Yair Levy, and I'm a hematologist-oncologist specializing in lymphoma. I've spent 25 years treating follicular lymphoma, or FL, and a lot has changed. What hasn't changed is that FL is characterized by repeated relapses and progressively shorter response durations with each line of therapy, reinforcing the need for treatment that delivers strong efficacy balanced with safety. MONJUVI, or tafasitamab, in combination with lenalidomide and rituximab, is indicated for the treatment of adult patients with relapsed or refractory FL. Limitations of use. MONJUVI is not indicated and not recommended for the treatment of patients with relapsed or refractory marginal zone lymphoma outside of controlled clinical trials. MONJUVI plus R squared is the first and only CD19 and CD20 targeted immunotherapy combination approved for second-line plus follicular lymphoma patients. Up front, I'd like to mention that the National Comprehensive Cancer Network, or NCCN, Clinical Practice Guidelines in Oncology recommend tafasitamab or MONJUVI in combination with rituximab and lenalidomide as a Category 1 preferred second-line or subsequent therapy option, if not previously used for FL after one or more prior systemic therapies, including an anti-CD20 monoclonal antibody. Currently, only non-chemotherapy treatments have NCCN Category 1 recommendations for second-line FL. According to the NCCN guidelines, R squared alone is not a Category 1 preferred treatment for second-line FL. Let's talk about the robust study design. MONJUVI plus R squared was studied in inMIND, a Phase 3 double-blind international multi-center study of 548 adult patients with relapsed or refractory FL grade 1, 2, or 3A after at least one systemic therapy, including an anti-CD20 antibody. Patients were randomized 1-to-1 to receive 12 cycles of MONJUVI plus R squared or placebo plus R squared. The primary endpoint was investigator-assessed progression-free survival, or PFS, using the Lugano criteria. Now, let's take a look at the patient characteristics in the inMIND trial. Patients included 83% high tumor burden, meaning they met at least one Guelph criteria, 43% refractory to prior anti-CD20 therapy, and 32% POD24, or progression of disease within 24 months of initial diagnosis. It is encouraging that inMIND included many tough-to-treat patients that reflect the patients I see in my practice. Now let's discuss the PFS benefits. We'll look at both Independent Review Committee, or IRC, assessed PFS and investigator-assessed PFS. Results showed a consistent benefit across both measures. There was a 59% risk reduction in disease progression or death with MONJUVI plus R squared as assessed by IRC. Median PFS was not reached with MONJUVI plus R squared versus 16 months with R squared. Note that PFS by IRC assessment was a secondary endpoint and not formally tested for statistical significance. For investigator-assessed PFS, the primary endpoint, the median PFS was 22.4 months with MONJUVI plus R squared versus 13.9 months with R squared, with a hazard ratio of 0.43 after a median follow-up of 14.1 months. There was a significant 57% risk reduction in disease progression or death with MONJUVI plus R squared versus R squared. In my opinion, these PFS results highlight a compelling benefit from MONJUVI plus R squared. As mentioned when we reviewed the baseline characteristics of inMIND, the trial consisted of 32% POD24 patients and 68% non-POD24 patients. Note that the POD24 subgroup analysis is exploratory in nature, and inMIND was not designed or powered to evaluate and compare multiple subgroups. These results should be interpreted with caution. A consistent PFS benefit was observed with MONJUVI plus R squared across patients who relapsed within 24 months of initial diagnosis and patients who relapsed after. Another endpoint I consider is a time to next treatment, which is especially important for an indolent lymphoma like FL. Median time to next treatment was not reached with MONJUVI plus R squared versus 28.8 months with R squared. An estimated 78% of patients receiving MONJUVI plus R squared did not receive subsequent treatment at 2 years after randomization versus an estimated 57% of patients receiving R squared alone. Note that this analysis is exploratory in nature and should be interpreted with caution. In FL, transformation to a more aggressive lymphoma is always one of my concerns. It's notable that at the time of the primary analysis, no patients had transformation to diffuse large B-cell lymphoma, or DLBCL, with MONJUVI plus R squared. 9 patients had transformation to DLBCL with R squared alone. Note that this analysis is exploratory in nature and should be interpreted with caution. Before the approval of MONJUVI plus R squared, our second-line follicular lymphoma treatment strategy included retargeting CD20 alone. The efficacy data of the inMIND trial demonstrated the power of combined CD19 and CD20 targeted immunotherapy was more effective than CD20 retargeting alone. Now let's talk about safety data from inMIND. MONJUVI plus R squared had a comparable safety profile versus R squared alone. A similar rate of adverse events of any grade was reported for MONJUVI plus R squared at 99% versus R squared alone at 99%. A similar rate of grade 3 to 4 adverse events was reported for MONJUVI plus R squared at 71% versus R squared alone at 69%. Adverse reactions that occurred more frequently, greater than a 5% difference, with MONJUVI plus R squared versus R squared alone included COVID-19 infection, pneumonia, diarrhea, and pruritus. Other adverse reactions that happened more frequently with MONJUVI plus R squared included fatigue, musculoskeletal pain, and mucositis. These adverse reactions are known and familiar to my clinical experience in the treatment of follicular lymphoma with R squared alone. MONJUVI plus R squared is a 12-cycle fixed-duration treatment. It can be administered close to home with no requirement to remain in proximity to a healthcare facility for close monitoring after treatment. This is an important consideration in treatment selection for patients with FL. MONJUVI should be administered with immediate access to emergency equipment and appropriate medical support to manage infusion-related reactions. I'm pleased to have tafasitamab or MONJUVI plus R squared as an NCCN Category 1 preferred treatment option for my patients with second-line follicular lymphoma. MONJUVI plus R squared delivered superior PFS benefit versus R squared alone. In addition, MONJUVI plus R squared has no hospitalization required for administration and can be administered close to home with no requirement to remain in proximity to a healthcare facility for close monitoring after treatment. These factors and the inMIND results suggest MONJUVI plus R squared is an effective therapeutic option for second-line follicular lymphoma patients.
Important safety information. Warnings and precautions. Infusion-related reactions. MONJUVI, tafasitamab-cxix, can cause infusion-related reactions, IRRs. In inMIND, infusion-related reactions occurred in 16% of the 274 patients with FL who received MONJUVI in combination with lenalidomide and rituximab. Signs and symptoms included fever, chills, rash, flushing, dyspnea, and hypertension. These reactions were generally managed with temporary interruption of the infusion and/or with supportive medication. Premedicate patients prior to starting MONJUVI infusion. Monitor patients frequently during infusion. Based on the severity of the infusion-related reaction, interrupt or discontinue MONJUVI. Institute appropriate medical management. Myelosuppression. MONJUVI can cause serious or severe myelosuppression, including neutropenia, lymphopenia, thrombocytopenia, and anemia. In inMIND, among 274 patients with FL who received MONJUVI in combination with lenalidomide and rituximab, New or worsening grade 3 or 4 cytopenias included decreased neutrophils in 48%, grade 4, 19%, decreased lymphocytes in 22%, grade 4, 1.8%, decreased hemoglobin in 9%, and decreased platelets in 8%, grade 4, 4%. Febrile neutropenia occurred in 4.4%. Monitor complete blood counts, CBCs, prior to administration of each treatment cycle and throughout treatment. Monitor patients with neutropenia for signs of infection. Consider granulocyte colony-stimulating factor (GCSF) administration. Withhold MONJUVI based on the severity of the adverse reaction. Refer to the lenalidomide prescribing information for dosage modifications. Infections. Fatal and serious infections, including opportunistic infections, occurred in patients during treatment with MONJUVI and following the last dose. Among 274 patients with FL who received MONJUVI in combination with lenalidomide and rituximab in inMIND, grade 3 or higher infections occurred in 24%, including fatal infections in 1.1% of patients. The most frequent grade 3 or greater infections were respiratory tract infections, 19%, including grade 3 or higher pneumonia, 14%, and COVID-19 infection, 11%. Opportunistic infections of any grade occurred in 6% of patients, including herpes simplex or zoster infection, 5%, fungal pneumonia, 1.1%, including pneumocystis jirovecii pneumonia in 0.4%, and cytomegalovirus, CMV, reactivation, 0.4%. Monitor patients for signs and symptoms of infection and manage infections as appropriate. Consider infection prophylaxis per institutional guidelines. Consider treatment with subcutaneous or intravenous immunoglobulin, IVIG, as appropriate. Embryo-fetal toxicity. Based on its mechanism of action, MONJUVI may cause fetal B-cell depletion when administered to a pregnant woman. Advise pregnant women of the potential risk to a fetus. Advise women of reproductive potential to use effective contraception during treatment with MONJUVI and for 3 months after the last dose. The combination of MONJUVI with lenalidomide and rituximab is contraindicated in pregnant women because lenalidomide can cause birth defects and death of the unborn child. Refer to the lenalidomide prescribing information on use during pregnancy. Adverse reactions. In the MONJUVI arm, serious adverse reactions occurred in 33% of patients, including serious infections in 24% of patients, including pneumonia and COVID-19 infection. Other serious adverse reactions in greater than or equal to 2% of patients included renal insufficiency, 3.3%, second primary malignancies, 2.9%, and febrile neutropenia, 2.6%. Fatal adverse reactions occurred in 1.5% of patients, including from COVID-19, sepsis, and adenocarcinoma. Adverse reactions led to permanent discontinuation of MONJUVI in 11% of patients and dosage interruptions in 74%. The most frequent adverse reactions leading to dosage interruptions of MONJUVI were neutropenia, 37% of all patients, COVID-19, 22%, pneumonia, 11%, and infusion-related reaction, 8%. The most common adverse reactions, greater than or equal to 20% in people receiving MONJUVI, were respiratory tract infections, 56%, including COVID-19 infection and pneumonia, diarrhea, 38%, rash, 37%, fatigue, 34%, constipation, 29%, musculoskeletal pain, 24%, and cough, 21%. The most common grade 3 or 4 laboratory abnormalities, greater than or equal to 20%, were decreased neutrophils, 48%, and decreased lymphocytes, 22%. Please see the full prescribing information for MONJUVI at www.monjuvi.com/monjuvi-prescribing-information.